I believe what I'm about to share with you is sort of the future of dentistry. And one of the hardest things for me, once I learned biomimetics, was there was such a difference in pattern of practice that it was hard to incorporate biomimetics as I was a in-network doctor. I was in-network with 17 different insurance plans. Almost went out of business because I got so good at avoiding root canals, crowns, and extractions. And I think that is one of the hard things is for us as a biomimetic dentist, especially a new one, to say, how can I sell this to patients? How can I deliver more care and have them afford it, but also have your fees with something that they're used to.
And now for the coup de grace. When it's not your money paying for something and you don't use it, then you're not concerned about either the price or the quality. Suppose the boss gives you $150 to buy a door prize for the office party. In a store window, you see a 6-foot tall stuffed frog marked $149. You think, oh, that's perfect, let's buy it. The raffle winner is awarded the 6-foot frog. Everyone laughs at the gag. Now this is called a third-party purchase. A purchase that is made with money that's not yours. Therefore, you don't care about the cost.
So the point being with this discussion is third-party insurances are companies that don't use your services and they don't pay for them. They use the services they use the money of the patients. And that is one of the problems with our healthcare system in general, is doctors don't own the insurance. They don't own the way to get paid for what they prevent. So this is a great case that I want to explain the difference between fee-for-service dentistry and value-based compensation systems. So what you're seeing, this is about I believe this is a 6-year progression of a patient that I have treated, 8 or 9 years ago. The patient came to me for a second opinion after seeing a board-certified pediatric dentist at 3.5 years old. They were told that they needed 4 crowns on their anterior teeth, pulpotomies in an OR setting. This is very standard. There's nothing wrong with that treatment plan. That's the way pediatric dentists are trained, at least here in the state of Texas. If you have 3 interproximal cavities by 3 years old, 4 by 4 years old, then everything gets crowned. Everything starts to talk about pulpotomies and root canals because obviously this patient has a high caries risk. We found out this patient had a confluence of factors. Mother didn't understand the way the caries progressed, didn't understand acid. So we had a long discussion on oral hygiene, health, nutrition, acid, the way caries progresses. And all I did, I used ozone to disinfect the teeth. We discussed with mom on how to remineralize the teeth or at least halt the progression of dental disease, and we didn't do anything other than that. So we're going to take this a step further. This is based on my study of utilization rates in the United States. Basically, composite restorations last 5 years. They typically get replaced. They last a little bit longer. They typically get replaced in crowns in the United States currently based on accepted insurance replacement schedules or a 7 to 15 year interval. After 7 to 15 years, they end up having to get replaced a lot of the times with root canal. And then once that happens and that fails, then we're talking about with an implant and crown. So what you're going to notice is the insurance companies know this. And the key on insurance is you look for predictability, and it doesn't necessarily matter the pattern of practice. As long as the insurance company can predict it, then they can budget for that. So insurance companies, for the sake of simplification in this chart, they make 20% off every premium dollar that goes into their pocket. So even though that they're budgeting $130 for the PPO dentist to place a composite restoration, they're going to still make their money because they understand that they're going to have to pay for that. So this was the last time I really spent a lot of deep dive in this back in 2019. Obviously, I'm much further than this now. And so what you're looking at is this is called a mirror image utilization control study. So we're doing June 30th was when I first met David Alleman. So I took the 3 years prior to June 30th, and then I took the 3 years after June 30th. So I obviously am doing more stress-reduced biomimetic composite restorations. I'm now no longer doing any full coverage crowns. We're doing onlays, and I'm not even needing the number of the root canals. And so in that 3-year period of time, my patients saw a 56% reduction in services. So I'm saving them money. They're very, very happy. But the hard part is how do I price my fees if we're not doing this? And so one of the things I'm going to talk about here is me going back to business school and learning generally accepted price strategies rather than using fee surveys to talk about this. And so this is from a dental group by a great dentist who owns a training academy for dentists. And this is the view of a fee-for-service dentist is, producing more dentistry starts with the decision that you want to produce more. Before getting more new patients or learning new procedures, I'm going to add to that, or before understanding the disease burden of your patient population. And this is the basis of the problem with fee-for-service dentistry. If someone needs more work than there is an out-of-pocket. So you need $2,000 worth of work, $1,500 is discounted. You would have a $500 out-of-pocket over and above your copay. I am toying with creating a all-inclusive plan based on risk, where there will be no max. And it's something that I'm interested in because, like I said, this is all mathematical calculations. Part of the way insurance is modulated it is due to the out-of-pocket max. And one of the things that we say is like, no one really likes coming to the dental office. You could do 12 cleanings a year and it'd be paid for. But that hasn't been an issue. But when you start talking about very large scale treatment plans, like I said, there has to be a level of accountability, and healthy patients should not be punished for a few number of patients who need very, very large scale treatment plans, because it disbalances the system. And if you have a disbalance in the system, it doesn't work for anyone else. And I think that is something that we need to be mindful of when I talk about this, is patient accountability, one, dentist accountability, and insurance company accountability. We all need to be accountable for the way that we alter the system going forward.